Hello, my name is Jeff Kane, Captain at EMS 703 on C Shift, and also an Assistant Quality Assurance Officer. For today's professional development video, we'll be discussing all things ketamine. I was tasked with discussing some current trends seeding ketamine administrations. There have been a few things noticed by the Quality Assurance Office that warranted discussion, but all in all, ketamine has been going well. I'll begin the discussion by covering an overview of pain management. Pain management is covered in Section 4.10-A of the Maryland Medical Protocol. This section offers three options for the management of pain: fentanyl, ketamine, and Toradol. Please remember that Toradol has a contraindication of trauma with suspected bleeding. Therefore, we should rule out Toradol for trauma patients, leaving us with two options, fentanyl and ketamine. Remember that the protocol dictates 2 doses and then consult. Using your best clinical judgment, decide on which option to use for pain management, but consult is required following 2 doses. This can be 2 doses of the same medication or 1 and 1. For example, you can give fentanyl and then ketamine, or ketamine and then fentanyl, or 2 doses of fentanyl and 2 doses of ketamine. But remember, 2 doses, then consult for additional pain management. Another thing that has been observed by EMS is hospitals or physicians providing negative feedback or having disdain towards our ketamine administrations. Although everyone has an opinion or preference on how to best manage a patient's pain, please do not let any previous pushback sway your clinical decision-making. If pain management is indicated and your treatment preference is ketamine, you should continue with the treatment as long as it's based off of sound clinical judgment and has the best interest of the patient's needs. However, if you consult for additional pain management doses and the physician orders fentanyl, you should follow that order or discuss why ketamine may be more appropriate for the patient's treatment. Now, on to the main topic, ketamine. As Dr. Stone says, this is a by-the-book medication. Patients can have unwanted and undesirable outcomes from overdoses as well as underdoses. Every dose is weight-based, therefore spot on to achieve the desired effects of the treatment. Unlike other medications, ketamine must not be titrated. Follow the exact dosing set forth in the Maryland Medical Protocol. As a reminder, 100% of ketamine administrations receive review from the Quality Assurance Office. Indications. There are 4 indications for ketamine with varying dosing. The first indication is pain management. Second, severe agitation. Third, ventilatory difficulty secondary to bucking or combativeness in intubated patients. And finally, CPR-induced awareness. Routes of administration. There are 4 routes that ketamine can be administered: IV, IO, IM, and IN. IV and IO are interchangeable and always the same dosing. IM and IN also share the same dosing. Concentrations. Montgomery County Fire Rescue carries 2 different concentrations of ketamine. They are referred to as low concentration and high concentration. Low concentration is packaged as 200 milligrams in 20 mLs, which equals 10 milligrams per ml. The vial states slow IV or IM use. High concentration is packaged as 500 milligrams in 5 mLs, which equals 100 milligrams per ml. The vial of high concentration states concentrate and must be diluted prior to IV use. Montgomery County Fire Rescue does not dilute ketamine for IV use. Therefore, high concentration is for IM or IN only. Low concentration is for IV and IO. It is key to remember high concentration for IM and IN and low concentration for IV and IO. Dosing. For this discussion, I'm only referring to adult dosing as described in the Maryland Medical Protocol. I'll break the dosing down by the indications and the routes. Pain management. IV, IO, 0.2 milligrams per kilogram with a max single dose of 20 milligrams slow IV push over 1 to 2 minutes. IM or IN is 0.5 milligrams per kilogram. For severe agitation, IVIO 1 milligram per kilogram with a max single dose of 100 milligrams and can be repeated once. IM or IN is 4 milligrams per kilogram with a max single dose of 400 milligrams, and consult is required for any additional doses. Ventilatory difficulty secondary to bucking, IVIO 2 milligrams per kilogram over 1 minute. 2 more additional doses can be given at half the dose, therefore making the repeat doses 1 milligram per kilogram. There is no IM or IN dose. Also remember, the patient must have an advanced airway in place. This means an ET tube or iGel. Do not dose the patient to facilitate intubation attempts. This indication is to prevent ventilatory difficulty secondary to intubation. And finally, CPR-induced awareness, IVIO 1 milligram per kilogram to a max of 3 doses. There is no IM or IN dose, and consult is required for any pediatric dosing for CPR-induced awareness. Another guiding document to remember is Clinical Practice Guideline 2023-01. Dr. Stone and Montgomery County Fire Rescue Leadership issued this clinical practice guideline on April 6, 2023, with the intention to temporarily change the indications and limit the routine use of high concentration ketamine to IM only to treat severe agitation. This CPG is still active and should be abided by when factoring ketamine into your treatment plan. This CPG limits high concentration ketamine use to the IM treatment of severe agitation only. The CPG simplifies the decision-making process on what concentration should be administered between the 4 indications. Per this CPG, if you are using high concentration ketamine, it should only be an IM injection to treat severe agitation. All other indications of ketamine should be low concentration and be administered IVIO. Documentation, everyone's favorite topic. Documentation is just as important as any other aspect of the incident. The narrative is your chance to document your clinical decision-making thought process and have reliable recall if the incident is ever part of a review or legal case. Please do not use the auto-generated narrative alone. If you do, please read over it and determine if there is enough information for an outside party to understand the incident or follow your thought process. My guess is there won't be enough valuable information in the auto-generated form alone. Therefore, if you use it, please add more than just the basics. Attention to detail is a must. In the PCR, specifically the narrative, please include the weight you used to calculate the dosing, the actual dose you gave, the route you gave it, and the concentration you used. There are 3 areas of the PCR to cover this information: the medication section, the controlled medication section, and the narrative. Specific to severe agitation, documentation is even more paramount. The narrative should cover what made the patient escalate to the level of severe agitation as opposed to mild or moderate. Also, did you consult for ketamine in case of severe agitation? If not, there should be clear documentation as to why the patient presented an immediate and imminent danger to themselves or EMS. When responding alongside law enforcement, we need to remember that it is our duty to care for the patient, not assist law enforcement. Any EMS action or intervention must be directed towards patient care after an assessment, not just arriving and assisting the police with restraining, subduing, or detaining the patient. Your clinical decision-making process to treat severe agitation must be based on the foundation of a patient assessment with objective and documented clinical findings that support the intervention. Remember to remain calm, courteous, and professional. Remain patient-centered, fully assess and have your gear at the patient's side. If you witness any misconduct, be an advocate for the patient and treat appropriately based on sound clinical judgment. To wrap things up, please remember ketamine is an exact science. and likely the most complex drug we carry. We carry 2 concentrations, and every indication has a different subset of dosing based on the multiple routes of administration. Take the time to ensure the proper dose is being calculated. Please use other ALS resources on scene, the Maryland Medical Protocol apps, as well as HandTevi to ensure the proper dosing. A big takeaway for today should be low concentration is given IV or IO to treat pain, bucking, and CPR-induced awareness. The routine use of high concentration ketamine should only be given IM for severe agitation. If it comes down to any last-minute confusion, read the label on the high concentration vial. Must be diluted prior to IV use. Since we do not dilute, do not draw up the high concentration for IV injection. Instead, move to the low concentration for IV IO administration. And once more, please document well, and attention to detail matters. Thank you for your attention, and please do not hesitate to reach out with any additional questions, concerns, or clarification.